Good afternoon, everybody, and welcome to the U Arizona Health Sciences Tech Talk Tuesdays. Tech Talk Tuesdays is a series of biweekly conversations all about engaging thought leaders, experts, researchers, and healthcare professionals in conversations around the advancement of technology in health sciences. We're happy to have Tara Sklar and Catherine Huber with us today. Tara is a professor of health law and the director of health law and policy program at the University of Arizona, where she launched and oversees multidisciplinary online graduate and undergraduate programs in health law. These programs include over 20 courses in aging law and policy, health information, privacy and data security, health law for health professionals, and regulatory science. Her research focuses on how laws and policies influence the health and well-being of older adults. Her work has appeared in many peer-reviewed journals, such as the New England Journal of Medicine, Journal of Empirical Legal Studies, and Gerometrics, among others. Catherine is an internal medicine resident at the University of Colorado Health Systems. She's an affiliate to the University of Arizona as a designated campus colleague to the College of Law, where she collaborates in teaching graduate courses in healthcare and ethics through the Health Law and Policy program, and through the College of Medicine, where she's taught foundational biomedical ethics courses for medical students. Her research interests focus on the ethical interface of new technologies and healthcare, particularly involving the care of older adults, and clinical skills development, ethics education curricula for undergraduate medical students. After today's presentation, we'll open up at the end for questions, which you're welcome to submit via the chat, or at the end, if you just want to jump in and ask directly, that's great too. And we will be posting a recording of this talk on the U Arizona Health Sciences YouTube page, and I'll be sharing the slides from the talk as well. And with that, I'll turn over the time to Tara and Catherine.
Great, wonderful. Well, thank you so much, Caitlin. It is a pleasure to be here. I've been delighted with your support organizing the talk for today, as well as the whole Tech Talk Tuesday series. So it's just wonderful. And I actually want to take a quick moment to recognize how this particular project seems to tie in very well with the faculty and advisory group that over at the Health Sciences, where this is a cross-disciplinary project. When Catherine was over at the College of Medicine in Tucson, she TA'd and was a student in our health law courses. And also the topic and theme of our project ties in really closely with one of the health science strategic initiatives that Dr. Kathy Insel is leading on the new generation model for healthy aging. So it just seems like there's so many links with what we're doing right now and what seems to be happening with the goals with Tech Talk Tuesday and the faculty and advisory group. So with that, I'll go ahead and get started. Being from the College of Law, I have a disclosure slide. So we will be discussing current and proposed legislation, but by no means is this legal advice. And what we'd like to do over the next 40 minutes is we're going to split our talk into exactly 20-minute sections, where I'd like to take some time and talk about what we're really seeing in terms of long-term care shifting from being in more of an institutional congregate setting to home and community-based care, and then how that's really been accelerated with COVID-19 and different technology advancements, particularly in digital health and telehealth. And what this means in terms of privacy implications, specifically for an older adult population. And then Catherine's going to build on some of those specific vulnerabilities for older adults and how technology is or isn't being adapted to them, some implications for other vulnerable populations, and lastly, some recommendations. We do realize this is a space in which we're going to see more and more technology involved, and what we're trying to do with this series of papers that we're working on is to really propose how this technology could be adapted that really keeps in mind the preferences and values of older adults. So why are we focused so much on this particular issue right now? These are headlines that you see daily, and it's just describing what's been happening with nursing homes and long-term care facilities, where because of COVID-19, there's just 40% of the deaths in America are from nursing home residents and long-term care facilities. And so you're just seeing more and more of a shift that was happening even pre-COVID, but even more so with those not wanting to be in those types of institutions and wanting to age in place. But what's interesting is this long-term care industry in general is that this is just something where there has been for quite some time ripe for disruption. So this was an article that came out in Forbes just a little while ago in September. And what I think is notable about it is I found that even though it's quite critical of long-term care facilities and how to fix this industry, I noticed that the industry groups, including the International Council of Active Aging, Leading Age, actually really referred to this article and said, yes, we know we have issues with staffing. We know we have issues with trust in terms of how to adequately prepare for infectious disease emergencies, and both seem to be, both in terms of institutional care and home and community-based care, are really looking towards technology for possible solutions. So that's why we're really going to focus this talk on technology in the long-term care space. So as I go through my talk today, I'm really going to focus in 4 areas. I want to take a little bit of time to describe how long-term care is delivered and financed and how that's changing with the COVID-19 and some of these technology advancements. And then lastly, get into sort of the big data issues, because as these technology devices are developing, it really is turning into 24/7 continuous monitoring, where a great deal of data is being collected and used and shared and sold. And it's not always clear what the guidance and safeguards are to protect individual rights over privacy. So I'll expand on that a little bit, and then Catherine will get more into some recommendations about what we can do about it. So I wanted to begin by just describing like what long-term care is. I realize that many people on this call have different levels of knowledge about what it could look like. So you have what you see a lot in the headlines right now with the nursing homes, assisted living at more of the higher end, more costly, and then less costly are in the home and community-based to provide long-term care. But what's notable in both of these areas is when you compare the cost of long-term care to an average income level for a senior, it far exceeds it. And so that's why we're getting much more involved with how to adequately fund long-term care, regardless of whether it's an institution or delivered in the home. So part of the reason for how it's difficult to think about this issue is that it really varies depending on the individual how much long-term care they need, both in terms of intensity and duration. So for about half of the individuals, and I've highlighted it here with a little square, it's about less than a year that they're really going to need this type of support. But for others, it can be as many as 5 years. And in addition, the cost of how it's provided can vary dramatically, as you see in the next panel in the graph. They compared Connecticut and Texas as the huge variation in how much it could cost to receive long-term care. And there are individuals end up spending all the way down to all their savings to end up qualifying for Medicaid. So as a result, Medicaid is the largest payer for long-term care in the US. With that in mind, it being a government payer, it's looking for how to manage these costs, knowing that we have an aging population. So starting in about 2000, you see this shift happening between how Medicaid is reimbursing for long-term care, where it's doing less and less of the purple line, which is the nursing homes and the institutions, and more with it's HCBS is the acronym for Home and Community-Based Services. However, this being America, the states really vary with how they provide long-term care. And so some states really are still under this institution, funding long-term care through institutions, whereas others, the ones that are in the much darker blue, prefer to invest more in the home and community-based services. So there's great experimentation happening across the country. What is notable is just thinking about the end user, which we try to do quite a bit throughout our work, and what they would actually want. Do they prefer to be in a nursing home facility or long-term care facility, or would they prefer to be in their home as they age? And so this was a study that was done in 2016, and it compared individuals that were in nursing homes that were then transitioned back into the home and community. And pretty much in every factor that's reported here, they reported greater satisfaction with aging in the home and community. And then the most notable difference was satisfaction with the living situation. I do think it's helpful to think about long-term care from an international perspective. And I thought this graph was quite striking, which just came out this year, looking at OECD countries. And it's no surprise that the US spends a great deal more on administrative costs. That's not a secret. But when you compare that it's almost double with in terms of long-term care dollars. That really is quite striking. And then some of the other variations are in the workforce, where this is a graph indicating where the United States sits with other OECD countries in terms of long-term care workers. And by far, it's still, even though we're moving more and more towards home and community-based care, it's still here's the United States on the graph. It's still based in predominantly institutional care. And it's just striking that right next to the United States is Israel, which has the exact inverse. So just a little bit of perspective about where dollars are going in terms of healthcare with long-term care in mind. It really isn't anywhere near what it is in other countries, and that's for a variety of reasons. But something to think about as you think about future funding. So I'd like to talk about how COVID-19 is impacting this area. And like one thing that's happening quite a bit is that there's just great concern across everywhere, but nursing homes and home health care in terms of how to properly protect against infections, how to have PPE. And so what this graph shows, I thought was just so interesting, is it compares home and community-based services in one line and one column, and then institutional care in the other, and shows the significant concerns they have, whether it's related to workers or access to PPE. And by far, it was the worker supply that seemed to show much more significant concern in terms of the institutional care versus home and community-based care. And that could also be related to the infection rate, which you see similar, much higher in institutions versus home health. And this is some of the reason I think driving what we're seeing right now with more and more people opting as much as possible to not go to these facilities, especially during the pandemic, and the impact of that on the long term. The other major impact that happened with COVID is this idea of saving hospitals with nursing homes. So when New York was experiencing their huge surge in the spring, Governor Cuomo passed this really controversial executive order that really gave limited options for nursing homes to not accept residents who were recovering from COVID. And he has a terrible quote where it's not our job to ensure that nursing homes have adequate PPE, but meanwhile, they don't really have the greater access that hospitals do have, and they aren't a priority. And so to send a patient back who's still contagious puts the whole facility in danger. So this was eventually rescinded, but was interesting, before that executive order was rescinded, it led to this other passage of laws that basically just protected nursing homes from liability, which isn't really the same thing as trying to help them improve their quality and safety with adequate staffing and PPE. You're still putting the residents in harm's way. So I highlight this in an article that I wrote with Professor Nicholas Terry at Indiana about what we could do differently in terms of looking at how to help nursing homes adequately deal with the pandemic. And it's not passing laws that shield them from liability, it's helping them get greater access to PPE and not sending residents, as they're still recovering from COVID, back to those facilities if they can't adequately isolate them. So that's another just impact that's happening for why less and less people are turning to nursing homes and trying to age in place and age in the home community. And the other thing that's happening with how the funding is being distributed during COVID, which is really quite striking, is that huge amounts, you hear about it regularly, of how we need to help nursing homes, we need more dollars to help nursing homes. It's an unprecedented act that's happening with the pandemic. And so there are large distributions happening from home and human services, but they're looking at the number of beds. They're not looking at, which nursing homes in which areas have the highest surges, which ones need more PPE, which ones have really poor staffing. They don't look at the rating system from CMS. It's just solely about beds. And I think this is really going to impact nursing homes that have that are on the smaller size, who just don't have the economies of scale that the larger multi-state facilities have. And so going forward, it seems likely that these smaller facilities are going to have a much more difficult time staying in business while we're going through the pandemic and after, compared to larger facilities or just the transition that's happening in to home and community-based care. So I'm not really going to advocate one way or the other. I just wanted to bring up this larger trend that's happening. And I did write in a paper that was published last year that no matter where long-term care is delivered, it really needs to have the appropriate financing and oversight. And what we found is that the more that long-term care is delivered in the home, they just have an increased chance of invisibility. You don't really know what's happening in terms of caregivers. A lot of the time that does fall on family members who aren't receiving any kind of training or payment. And there's the quality assurance varies their own way of looking at how home and community-based services are being monitored. And so it's just alarming, knowing what we know about elder abuse and neglect, that to leave this as an area where we're just going to provide care in the home and not really give it proper financing or oversight is of high concern. And so one way to look at this is through technology, which brings us to the next slide. So technology is rapidly changing under COVID due to concern with how we can social isolate and still provide care, especially for older adults. Huge rise in telehealth for lots of reasons that I'll get into in a minute. And then very much related to that is what's happening with digital health, where we have these wearables and other remote patient monitoring devices. What I think is so key about what's happening right now, though, is we're seeing it really impact older adults, but Catherine and I really also want to emphasize how this could be applied to other populations, and just the idea are we really prioritizing efficiency over what these particular groups need in terms of quality care and making sure their voice is heard. So there's lots of reasons for why we're seeing so much technology innovation in this space. There's, of course, there's a desirability to prolong independent living, improve quality and safety, potentially save costs. As I've noted, the huge differences between paying for long-term care in facilities versus in the home and community. And then the graph to the right just shows the tremendous market size growth for in the digital health space. However, there are some serious concerns with hype and risks. Catherine and I talk about this a bit in the paper that we're working on, but it's not always quite clear whether some of these innovations and devices are really helping to improve health outcomes. And one that's gotten quite a bit of criticism is with bed alarms, where older adults are afraid to move, even like saying we feel immobilized because any movement may cause this like shrieking, piercing alarm to go off, which if you're recovering from hip surgery or fall, you want to get moving. So to be so fearful of potentially setting off a loud piercing alarm that you don't move could actually be very detrimental to your overall health outcome. And then just in general, there's quite a bit out there that we'll discuss more on, are older adults being included in the design of these different devices? And could it lead to potentially more isolation if they can be monitored from afar and aren't going to have regular check-ins by staff? And then there's just a sheer lack of standardization with how rapidly these different devices are coming out, both in terms of how they're going to deal with data privacy issues, but also just the clinical validity. It's not being something that the FDA is looking at in great detail, because a lot of the times they're considered wellness devices. So there's just a lot of ambiguity about what's happening here, even though there's tremendous promise and also a great deal of growth. We're not the only ones looking at this. Doug Greenbaum's done some really great work thinking about these devices in this space. And he basically developed this checklist that this article talks about, where it's really important to ask, like, is this sensor device, helping someone actually have greater autonomy and prolong independent living? Or is it something where their well-being isn't being prioritized as much as efficiency and these other categories of ulterior motivations, everything from saving cost and downward. It is important that I note just the trajectory that we're on, and that how many the older adults will surpass children under 18 by 2034, with 1 in 5 being 65 years or over. And I think what's also very much related to this is how much we're living longer. So 85 years and older is one of the fastest growing segments of our population. And I think it's so fantastic that Catherine is my co-author and co-presenter today, because she is one of our aspiring geriatricians, of which is not increasing nearly as rapidly as it should be based on that graph. So while it is going up a little bit, when you actually adjust for population increase compared to geriatrician, it's a decline of nearly a quarter, which is quite alarming. And another reason why we're looking at technology as maybe a way to help address address this gap. I thought it might be helpful to just focus for a second on how telemedicine connects to some of these digital health devices. And so this middle graph really shows an issue that's quite pertinent to an older population, where they just there's many issues related to chronic conditions and also medication adherence and management. And so that's one way you can really use sort of the telemedicine, telehealth interface, but you have the tracking with your wearable devices to see what may need to be tweaked. And as a result, you don't actually need to have a face-to-face visit. And here's a graph indicating how that actually would look. But what's notable prior to COVID is just the sheer relucance that older adults had to adopt this technology. So there was a poll that was done by University of Michigan last year, where it said there certainly was interest in looking at telemedicine as a way to have healthcare received. Very few individuals had actually had a visit. And these are all the different reasons they cited for why they haven't had one. They weren't aware maybe of exactly how it worked or how to go about having it. They had some fears about would they have the relationship to their provider, was their provider offering this type of healthcare service. Certainly there were some issues with sensory deficiencies or fear with using the technology, and the privacy issue was sort of mixed. For some individuals felt there could be more privacy where you were just in the privacy of your home talking about these issues, where others had serious concerns about everything being recorded and saved, and so they felt less likely to want to be less comfortable with the privacy element. Anyway, I bring that up because we've seen like this, well, I'll touch very quick. Sorry, I was going to give another thought, but it's too distracting. So I bring this up because we've seen this real incremental staging of like, should we do telehealth? How should we do telehealth? This promise of telehealth has been going on for 20 years. And earlier this year, pre-COVID, there was this big deal with Medicare Advantage. And the way Medicare is broken out, about 35% of all Medicare beneficiaries are on Medicare Advantage. It ends up being about 25 million people, 75 million are on Medicare overall. And so the way it was going to be rolled out was like, well, if you have Medicare Advantage in certain states, you can get access to telehealth, and they were going to lift this restriction where you could receive telehealth services within your home. And it was a really, really big deal. But then COVID happened, and it changed everything. So suddenly, like, anyone could get access to telehealth within their home. The numbers just expanded rapidly to 10.1 million now have received some kind of telehealth visits. And then the services have increased up to 135, which is remarkable in the last 6 months. So now the question is, is this something that CMS is just going forward, they're just going to, on a permanent basis, reimburse telehealth for wherever it might be delivered and no longer have these geographic restrictions? So it's a huge game changer. And lastly, just touch on the privacy issues that we'd like to talk about. So we don't have a federal privacy law in this area for the country. These images to the left here talk about what is in Europe with the General Data Protection Regulation, like California is looking at with their Consumer Privacy Act. And then on the last one is this legislation that was proposed in June of last year, looking at how we could potentially look at privacy issues and big data. But I think what's important with this legislation is the overall goal is that we really shouldn't be collecting data unless it's going to be used for a specific purpose to help really improve care, and then someone has the right to delete that data if they no longer want it in the public or don't want it to be used. And so what Catherine will be getting into in just a minute are all these issues surrounding consent and how data is collected and how that could change. And so these principles aren't mandatory for the country, but I think that they could really offer some helpful guidance in terms of what we actually need in this area to help give individuals more of a sense of protection about the data that's being collected. And this is just an example of how, because there isn't a national law, the states vary all over the place. So if the darker the state, the more privacy laws they have in effect. But that variation has serious implications as well. So I wanted to flash that. So with that, I will turn it over to Catherine and stop sharing. Great.
All right. Awesome. Thank you so much, Tara. That was incredible. Every time I hear you speak, I'm always like, I want to work with her. And now I get to say that I am. So hi, everyone. I'm zooming in from my clinic, which could not be more timely because speaking of the rise of telehealth, half of my patients today have all been telehealth visits and half have been in person. So I think that that's very salient to the topic today. The question is, how easily can I make my slides work? Perfect. So I'm going to talk a little bit more about the ethical groundwork and the ethical framework by which we have been thinking about these issues first solution. So for me, it's important to kind of start with, okay, what exactly are we talking about? What are our terms here? So one thing we talk about a lot in older adult care or care for people who are over the age of 65 is this concept of frailty. And it's, I think, a somewhat ambiguous term. In the medical field, we're pretty specific about how and why we use this term. So in the medical context, in the physiologic context, we think of frailty as extreme vulnerability. And that's vulnerability to different types of stressors. So we think about internal stressors versus external stressors. So if I'm sitting here in my medical clinic and I am looking at an older adult in front of me, and I'm going to use the diagnosis of frailty, there's a reason that I'm thinking about that term, and it's not just to describe somebody who, you know, was slow walking in the door or has a lot of medications. It's a pretty valuable descriptor in diagnoses. So in the medical context, we use this for diagnostic purposes, we use it for prognostic purposes, and for risk stratification. And frailty essentially means extreme vulnerability to poor outcomes or lack of recovery after a significant event. So for an internal stressor, that might be things like infection, malignancy, any acute illness would be an internal stressor that we might say, in these older adults who are more vulnerable to these stressors, they're unlikely to return to their baseline after this illness, or they're unlikely to fully recover back to their normal state. And then we also think about the factor of external stressors. You know, somebody who is medically frail may need additional support at home to overcome some of their limits, some of these vulnerabilities. And if maybe they don't have those home supports or a home support network or a accessible home, that's going to further limit their ability to recover from stressor or even continue living with their vulnerabilities. And I think it's helpful for me to explain that in medical terms, but I think it also kind of gives a practical application of why this term is important. But it's also valuable in thinking of these issues from a health justice approach. So why do we care about it in the big picture space? And I think that frailty is, again, useful for us in identifying folks who are going to be vulnerable to stressors from systems level and from inequities level, and those who are going to be susceptible to harm, and that maybe need additional protections or additional oversight, especially when we're employing new interventions, such as new technologies or new models of care. So it helps us identify who's at risk, but also how can we intervene, and you know, what other things that we can do to address them. So in older adults, there are multiple levels of vulnerability that we think about beyond you know, just abuse and neglect. And in my thinking, I think it's helpful to break it down to different factors that are specific to older adults. And I'm going to start with the structural level. So older adults face unique challenges and vulnerabilities in terms of you know, the rise of institutionalization of their care, the fact that they're interdependent on other adults and other members of their family or support systems, the fact that much of their care is determined kind of at policy level by Medicare and other regulatory bodies, unlike, you know, adults of younger ages or of different needs. Older adults also face particular vulnerabilities in terms of environmental factors. And this is, I think, something like an unseen challenge. You know, we think about ability barriers. You know, how easy can an older adult navigate their home space or their community space because they are reliant on a walker for ambulation or a wheelchair, or how easy is it for them to, you know, get in their car and drive across town to appointments to the grocery store. If you are lucky enough to be an older adult living in New York City, you have accessible options to transportation for your needs and to get around the city. But if you're an older adult in the middle of rural Colorado, you may not be able to make that journey the 5 miles down the dirt road to obtain the things that you need. And then kind of moving down the ladder to the smaller and smaller scope, we think about social barriers, and that's everything from literacy rates to socioeconomic needs and factors, as well as caregiver options and social supports in the home, through friends, through family, through, you know, their partners. And then, you know, what's their educational factor? What's their health literacy factor? And then thinking about, you know, novel technologies, you know, do they have access to Wi-Fi? Do they have connections in their home? Can they afford to buy these devices? And then finally, the things that I tend to think about most often is the cognitive and physical aspects. The cognitive being that we know older adults are much more susceptible to things like dementia, cognitive impairment, and that is especially true in older adults who have lower literacy rates or lower educational backgrounds. And then finally, physical barriers. As I mentioned, many older adults are in need of some kind of physical assistance for mobility, such as walkers and wheelchairs. But that even extends to things like hearing aids and you know, visual deficits from cataracts or just, you know, natural age-related vision loss. And so all of these factors can either be present altogether or just at one piece of the puzzle. But each of these are somewhat unique to older adults. They can definitely be found in other populations, but they definitely add to this sense of vulnerability, this sense of vulnerability to added stressors from internal and external trauma or issues. And so I think knowing that there are sort of multi-layers that come into play here and multiple barriers that may come into play is really useful, I think, in terms of why do we care so much about older adults as being vulnerable to new technologies. Well, it's because they're facing so many steps up the ladder, just to kind of be on par with a younger, healthier, kind of matched person. So again, thinking about older adults, what do we mean when we say heightened vulnerability? We mean that they face unique cognitive, sensory, physical impairments. Older adults have much higher rates of comorbidities. On average, I think there's some data that shows that on average, older adults are using at least 5 medications. And even a bigger portion of that, like 40% of older adults are on up to 10 medications at one time, multiple comorbidities. And then additionally, older adults have like a unique interface with this idea of consent. And, you know, I'll get into this in a minute, but these new technologies are not using these traditional ideas of consent that we base most of our decision-making interventions on. You know, we're talking about remote patient monitoring. Who is doing the consenting? How often are they revisiting consent for different technologies to be used for them? And then as these technologies change and we change what kind of data we're collecting and how we're using that data and how we're making decisions on that data, are we checking back in with those older adults to make sure this is something they still agree to and that they still are acceptable as part of their care? And then additionally, we think about issues such as social isolation and loneliness. Again, we know that older adults who are living at home are at much higher risk for isolation. And this is probably only going to be exacerbated by using technologies that just allow for continued removal of that human presence in the home, as much as we can substitute the hands-on care of checking vital signs or providing, prompts to stay in bed or safety prompts in the home. That's that's less time with a human interface in person, more time with a watch or a camera. So certainly that's going to pose some unique challenges. And then finally, as Tara mentioned, older adults are driving a lot of our healthcare spending, our healthcare resources. And so certainly this is a population we need to be mindful of how we're going to allocate resources, how we're going to use the data that we collect from these technologies to inform that resource allocation. And then how are we making sure that we're still providing high quality of care to our older adults with these technologies that maybe don't fall under traditional regulatory oversight through the FDA or through other regulatory bodies. Lots of factors that are coming into play, and when we're thinking about technologies in older adult populations, these are all major issues that are really clear in my mind. I'm biased because I care a lot about the care of older adults, but I think these are just really coming to the forefront now. So in COVID, even more than before. So why are we kind of trying to use a health justice framework, and why do we think that this is going to offer some kind of solution? Well, I think first we need to kind of define what we mean by health justice. It's been used quite a bit over the last few months, and I think for our terms, we want to make it clear what we mean by that. So health justice is truly a frame that's based on principles of equity. And this concept that we want to encourage and promote the ability for all people to flourish and to be free from hazards and barriers that we've placed on them, given sort of societal structures and environmental structures and barriers. These things that cause older adults to be more vulnerable to stressors and to harm are things that we want to work to overcome and level, if you will, for our older adults. And so, because our health systems and our policy systems and our social systems have created some of these barriers, health justice prompts us to then take a look from a policy standpoint and a regulatory standpoint to see how can we level those barriers, how can we overcome those and help older adults really thrive, to not only prevent harm, but also mitigate challenges that are already existing for them. And so I really wanted to kind of focus on, this is an international global concept of health justice, but, taken from the WHO report last year, pursuing health equity really means striving for the highest possible standard of health for all people and giving special attention to the needs of those who are at greatest risk of poor health. And so when we say our older adults are vulnerable, this is who we're talking about, those who are at greatest risk for poor health outcomes and so on. So kind of getting down to the nitty gritty. So I want to talk about informed consent. That's kind of the individual level, and we want to start to address some of these challenges and these barriers. So what are the problems with informed consent and these new technologies? As I mentioned, it's very different from kind of traditional approaches to informed consent that we're used to in the clinical or the research context. So I don't know if any of you have recently used a Fitbit or your Apple Watch or a Garmin, and if you've recently gotten one, you have to go through some consent processes. And these are somewhat similar to kind of the technologies that we're using in the home, these individualized personal monitoring devices and health sensors. So if you've ever used one, you've noticed that it's just a clicking game. It's all read, scroll, very fine print. And it's got multiple links that you can click through to get to, extra information about how your data is being used, how it's being protected, who has rights to that data. And this is speaking from the US perspective, of course. And so I just went through and took screenshots of some of my own monitoring devices, and I'm going to not, name names or point fingers at where these things are coming from. This is just to illustrate what do these consent practices look like. So then after you've consented to the use of this device, then, in theory, you have the option to go in through your own technology to identify, what components of monitoring do you agree to? What do you want to be sort of probed into on your own phone? And you can easily see how it's a multi-step process to get to all these controls, to understand what it is they're collecting, how they're collecting it, what are the safeguards, and who's going to be using your data after that. And I don't know if you guys have looked through it. I personally have a pretty small phone. It's already very fine print. So you can imagine an older adult, think of your grandparents or great-grandparents, going through their phone. Maybe they've already zoomed in the text, so that's one thing that they can do to help, but it's pretty dense, fine print text that doesn't really lend itself well to reading and discussion of some of these issues. And this is only exacerbated by people who maybe have visual impairments, who maybe have lower literacy or health literacy rates. We know that older adults have pretty low digital health literacy rates, and that's something that's kind of defined as how easily can people navigate things on the computer or on their phone. And it's pretty challenging, even for myself of a younger generation. And so when you think of people who maybe didn't grow up with these technologies, there's only additional barriers there. These things are from my own phone, but it's going to be something that's going to be present in a variety of forms from all kinds of different technologies. But it may not be so readily accessible as at your fingertips. It may be something that is a multi-step process to really see what those agreements were that older adults signed on for. And then there's the question, if we're applying these technologies to monitor folks and to help folks age, in their own space or in a facility space, many of these older adults have cognitive impairments, especially the ones who are in need of monitoring, in need of safety prompts and kind of continuous round-the-clock surveillance. There's the question of how and to what extent are they even consenting to the use of these technologies. And, if they are consenting, through what means is that? Is it through this click-through nature that is never revisited even after updates and changes are made to the technologies? Is it something that their guardian or their ND of POA is consenting to? Or is it something that is just kind of a part of the package when they enter, home care systems, or if they enter facilities? So there's a lot of issues here that I don't think we've fully confronted as a society or as a healthcare system that we need to be very mindful of. So one way that Tara and I have kind of approached this and said, well, what can we do about it? If our traditional models of consent, where it's individual-based, there's a one-time form or discussion around consent, this is probably not an adequate model for the unique challenges and unique circumstances of older adults. So what can we do instead? Well, we can rethink how we do consent. So one emerging framework in the literature is this concept of relational consent. This is something that's been borrowed from vulnerability theory and from women's literature or women's studies. This idea of relational consent, and it's based on the premise that people are not independent, isolated objects. That we exist in an interdependent network of relationships with our communities and the people around us. So that starts with the individual, sure. They're the ones who are at the center of the decision making. Their values are driving things, their goals are driving things, and their needs are driving things. But it also involves their caregivers. For some of these older adults, for them to exercise those values and their goals, they need a little bit of assistance. And sometimes their goals and values are directly influenced by their families and the people who are there on the ground with them, taking care of them. So it's this idea that as you move out in your surrounding network, this expands to your friends and your family and then to your community, that these are all players at work and driving that individual's decision making. So what does that actually mean other than just kind of abstract thinking? It means that when we're discussing risks and benefits, when we're discussing an intervention with the older adult, we're doing so being mindful of the way in which their decisions are driven by and aided by those around them. So that could be having those caregivers present at the time of that decision being made, at the time that we're, enrolling them in a wearable device. Having their caregivers also kind of consent to the use of that device, because some of these devices, like cameras, for instance, are collecting data on the caregivers as well. And if we treat informed consent as this, individual autonomous process, we're not even remotely considering the needs or the interactions with those around them. So a relational consent model really considers and takes into account all the players in the game. And so it's a more fluid model. It's a way of incorporating other people besides just one person who signs on the dotted line. And it also may give us an opportunity to revisit the consent process as technologies adapt and change over time. And as older adults maybe age over time and maybe they become more cognitively impaired or physically impaired, it allows space for caregivers and family members to be involved in that consent process in a more dynamic and an appropriate way over time. So this concept of relational consent we feel is a really promising area that maybe will offer us a way to address some of the challenges that exist today and give us a good way forward. So what else can we do? We can, as Tara mentioned, look towards more regulatory models. The ones that we have and the ones that are, proposed, maybe don't do enough or fully address the problem, but it's one place to start. And by starting there, I think we can then hopefully push to adopt more health justice framed ways of thinking or frame discussion of how can we level the playing field to reduce barriers, reduce vulnerabilities, and address discrimination and biases. And can we really focus on older adults as a vulnerable group that's subject to abuse and neglect and exploitation, and making that explicit in some of these policies and in some of this decision making, and considering that there are unique needs in the way that these technologies are being applied. And then as we have mentioned several times, this is just really booming in the time of COVID. COVID has really pushed for the further adoption of telehealth technologies, the invasion of technologies into the home space. Just today I sent patients home with pulse oxes and home BP cups, and it's not hard to see how in the future that might include cameras or watches and things of that nature. And then COVID again has really just heightened how little we have in place right now to guide us through this year. And again, COVID being what it is of a pandemic and a communal issue is I think making people much more aware and much more cognizant of the need for shared decision making and the involvement of the individual in healthcare decision making as well as policy decision making. So, to sum up, we think that it should start with rethinking how we're doing informed consent in a way that really acknowledges and incorporates the interdependent nature of older adults' lives and their existence. And also that we need to focus on how we can improve and address shortcomings in our privacy and security regulations. And then realign much of what we're already doing with a health justice focused approach to make sure we're really promoting equity and reducing discrimination and disparities. We hope that some of these changes will allow older adults to participate more fully, be more engaged in their care, for their family members to be more engaged, and to really empower older adults to live longer into their life and to be free from some of these barriers that already exist, and really empower that person at the center of the picture and that older adult kind of at the center of all of this to participate and be engaged. As a teaser, if you would like to learn more and engage in some of the ways that technology is influencing the aging process and are challenging our older adults, I encourage you to enroll in my class. That's a selfless plug. But for now, I think I've talked enough. We should probably turn it over for questions, so I won't do any more self-advertising.
Well, we have a few questions that got submitted to me directly in the chat. So let me just pull that up 1 second. All right, so the first one we got, I think is directed to Tara. It says, you mentioned an article you wrote about helping nursing homes during this time. What would you say out of all the recommendations you covered in your article is the most essential or the starting point on this journey?
Oh, that's a great question. Well, there was legislation proposed that really tried to more adequately put resources where there was the most need for them. And I'm happy to circulate that to Caitlin for the group to read. And basically really tried to tie in more metrics and more data with what was happening with nursing homes so that resources would flow more to those that were really having difficulties with having staffing, keeping staffing up, getting access to PPE. And it wasn't just based on beds, for example. It was much more tailored legislation where funding could flow where there was the most need for it and be more nimble using the regulatory oversight from CMS. So what constantly is happening in this area right now is that nursing homes are regulated by CMS, but many long-term care facilities are not regulated by CMS. So just to keep that in mind with this legislation is, even though we're talking about nursing homes, you could do that legislation. It's not something that would work for those that happen to be living in assisted living community centers or those that aren't receiving oversight from CMS. They aren't receiving that payment. So so it would have different remedies based off of that. But it is helpful legislation that gets to this idea where we, as much as possible, to look at the actual metrics and the need and tie funding to that, and not just this knee-jerk reaction where, regardless of how large the nursing home facilities, and some nursing home facilities are part of major corporations, such as the Kirkland site out of Seattle where the outbreak happened. That's a much different type of institution than another place that's down the street that might have 10 beds, and how they're trying to get PPE and deal with staffing and make sure that their employees are healthy, and how to handle it when a COVID resident may have an infection, or when a resident may develop a COVID-19. So I just wanted to highlight the differences be across the board within nursing homes, the large, medium, and small size, and those who aren't regulated by CMS. But I'd be happy to share that legislation. I thought it was just a much more transparent, promising way to look at this area.
Yeah, I will definitely send that out to our registrants. And then the other question I got is a bit more general. It said, how would you recommend practitioners that are currently working within telehealth to make it a little bit more accessible to elderly patients? Kind of things they can do on their own? Do you think it's more about the ease of the technology, or about being more open about procedures and privacy concerns?
Well, I can take I can take part of it, and then Tara, maybe you can hop in. I have a stronger feeling towards sort of the latter half of that question of, if we are more open about the policies and procedures that we're using to guide the use of these technologies in this population, perhaps that will lead to more feedback about what's the most appropriate way to engage older adults with new technologies. Right now, part of the issue is we're trying to transplant new technologies onto older adults without really taking their particular physical or cognitive needs mind when we're applying these. And I think that what we're advocating for is that maybe through more shared decision making, more discussion, they will tell us how we should best adopt technologies to their care. We already have challenges in getting technologies to people who have difficulty getting to the hospital or into a safe clinic space. These are only exacerbated in older adults. When you have additional challenges such as mobility or digital health literacy and things like that. I don't know that we have found any good solutions yet, but I think that the first barrier to that is the discussion and the transparency about what it is we need to do and how we can do it to best serve them. I don't know, Tara, if you had more to add to that.
Yeah, well, I actually have two thoughts. So the slide I didn't show because it was a little bit, it would have taken me off track of it, and I knew we had limited time to present. But it was basically from a New England Journal of Medicine article that said, and Catherine, you could probably speak to this better than me, but half the time when a patient leaves a doctor's office, even when it's face to face, they don't really comprehend what was said to them and what they need to do. So we have this interesting like black and white image of like in-person face-to-face visits versus telehealth, and really both models have pros and cons to it. Like there's nothing particularly amazing about having a 15-minute face-to-face visit with a clinician that spends the entire time entering the information in the electronic medical record anyway. So I just think it's helpful to think about both models together as opposed to like where telehealth might be lacking and what in person can do that it can't. And my other thought that we just didn't have a chance to talk about in our presentation was that there's different implications for an older adult when they're being recorded and monitored the way that is happening right now. But there's a lot of fear about their ability to stay within the preferred living arrangement. And so if you're constantly being monitored, they might think, oh, they saw that I had a memory lapse or that I forgot to do this, or maybe I had an incontinent issue and now I'm going to have to go to a nursing home. And like that level of pressure and anxiety that puts on you when you're being continuously monitored but not knowing how to stop it. And that's something that we're trying to get to that's very specific to an older adult population dealing with this continuous monitoring technology. And it's something that I think we should keep in mind before we keep saying, oh, this is for the benefit of everyone, that you just have this in the home and everywhere, when it causes a great deal of anxiety and fear. Or it can cause, I should say.
Yeah, thank you. So that's all I have from the chat, but for everybody in the meeting, if anybody has any questions, feel free to jump in. I think then that we're good. I think we've covered everything. Tara and Catherine, thank you so much for presenting today. Everybody, thank you so much for joining. And again, we'll have this talk posted on our Health Sciences YouTube channel, and I will send out the slides from Tara and Catherine to everybody who registered.
Oh, this was great. Well, thanks. So we're the final wrap up for the series. So congratulations.
Yes, thank you.
Finale.
And a great finale.
Oh, thank you. This is really fantastic. Thanks so much for joining us, and thank you for inviting us.
Yeah, thank you, everyone. Thank you, Caitlin.
Of course. Thank you, guys. Have a great rest of your day, everyone.